Yes, please.
My lady, I call, please, Professor Jonathan Wiley.
I swear by Almighty God
I swear by Almighty God
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
and nothing but the truth.
Can you give your full name, please?
Jonathan Peter Wiley.
Now, Professor Wiley, you have provided a signed witness statement. That's INQ 474274. And you explain in that witness statement that you have also adopted the witness statement of Professor Lockie, President of the Resuscitation Council UK. That is witness statement INQ 000343994, and you'll be speaking to that witness statement today.
That is correct.
Now, Professor Lockie, can I say at the outset that the inquiry is going to be hearing from 5 witnesses today? And can I ask you, please, at the outset to assist the inquiry in keeping your answers as concise as possible? Thank you. You are an executive member of the Resuscitation Council UK. I think that's right.
That's correct.
And the immediate past president, so you were the president during the pandemic, is that right?
That's correct. I was president from 2018 to 2021.
Thank you. Professor Lockie explains in his witness statement that the Resuscitation Council UK, and we might call it the RCUK for brevity, is responsible for issuing resuscitation practice guidelines and standards for the healthcare sector throughout the UK.
That's correct.
And I think the process for development of those guidelines is accredited by the National Institute for Health and Care Excellence, NICE, and it follows best practice for guideline development. And those guidelines are implemented across the National Health Service, social care, and in community settings. Is that right?
That's correct, for all 4 nations.
Thank you. You also explained that the core membership of RCUK comprises specialist clinical and academic experts who are recognised as international leaders in resuscitation, and indeed they play leadership roles with the International Liaison Committee on Resuscitation, ILCOR, and the European Resuscitation Council, the ERC, which scrutinise published scientific evidence on an international scale. Is that correct?
That's correct.
Professor Wiley, I'd like to focus on 3 topics today in which RCUK was involved during the pandemic period. Firstly, the guidance provided by RCUK around PPE, protective personal equipment, for healthcare workers performing cardiopulmonary resuscitation during the pandemic. Secondly, I'd like to look at the role of RCUK in advanced care planning across the UK and the RESPECT form that was developed by RCUK. And finally, I'd like to move on to issues that arose during the pandemic around DNA CPR notices and the making of those notices. On those latter 2 issues, we heard yesterday from experts in intensive care, and I think you are familiar with the evidence that they provided yesterday. Is that correct?
I am, yes.
We're not going to be going over the same ground today, but there are some matters in relation to those final 2 topics that I would like to pick up with you, if I may. Can we begin, please, this morning with cardiopulmonary resuscitation? And can we define what that is in a healthcare setting? What does the CPR procedure entail in a hospital?
So it is a treatment that can be instituted when a patient has a cardiac arrest, and that is not the same as a myocardial infarction, although that can lead to a cardiac arrest, but it's defined as an absence of breathing or of signs of life, and it is effectively your heart stopping pumping effectively. And
what actions have to then be undertaken by a healthcare worker if they were to perform cardiopulmonary resuscitation? What are the
initially, basic resuscitation, which focuses on chest compressions and ventilation breaths to support a circulation until more definitive treatment can be brought to bear, such as defibrillation, to revert the heart to a more normal rhythm, or advanced airway manoeuvres in order to more effectively do the breathing for the patient.
And is there any difference between the CPR procedure that's undertaken in a hospital setting and that provided, for example, by a paramedic, either in an ambulance or in someone's home if they've gone to someone's home?
So that there's very little difference in approach, but obviously there is a difference in timing. In a hospital, you are much more likely to have help immediately available with a national 2222 call goes out and an arrest team comes up, and there are likely to be healthcare professionals very close by. Obviously, in an out-of-hospital cardiac arrest, mostly you will be in your home. About 70% of cardiac arrests happen in your home, and the rest of the time you're more likely to be out and about with members of the public.
Thank you. I think we heard yesterday, I think it's correct, that the survival rates of CPR outside hospital is 8%, and the survival rate in hospital, so from the survival rate to hospital discharge for in-hospital CPR is 23%.
That's correct.
So, aside from the relatively low survival rate, what about the potential for CPR to cause harm to the patient? I'm thinking now particularly in a hospital setting rather than if somebody's having CPR on a pavement outside.
So in any setting, I think that what most people think of as CPR, most people think that it is just another treatment. But in actual fact, it is quite a violent procedure to compress a chest sufficient for the heart to pump blood around. And therefore, there is the immediate risk of harm, and up to 70% of adults who undergo CPR and chest compressions will have rib fractures, or large or small. Of course, that is recoverable. But the major issues for a patient are really whether they wanted to be brought back from what is effectively death, and that depends on the quality of life afterwards. So,
what about the potential for a patient who has received CPR in a hospital, who has been resuscitated, to be in a worse medical condition, a worse state than they were before they had the cardiac arrest?
that is always possible, and therefore one has to weigh the benefits to your patient against the potential harm. If your heart stops, then there is the potential for damage to organs, and especially the brain, from that moment onwards.
So is it the case that somebody could be resuscitated but be, for example, in a persistent vegetative state?
That is possible.
Professor Wiley, I'd like to come on to some of the issues that came up during the pandemic in relation to the guidance produced by RCUK concerning the appropriate level of PPE for healthcare workers performing CPR. And I think this is set out in some detail in Professor Lockey's witness statement, and I'm not going to ask you to give us the chronology of meetings and contacts between Public Health England and the Resuscitation Council UK, but I think, suffice to say, there was a divergence in the guidance that was given in the Public Health England, the UK IPC guidance, as we have been referring to it, was that they considered an absence of clear evidence that chest compressions in CPR, there was a lack of clear evidence that those chest compressions generated aerosols, and therefore full PPE was not a requirement for CPR.
Indeed.
And the position of RCUK was somewhat different. You've described it as a precautionary approach and advised that full PPE should be worn during CPR. Could you briefly summarise why RCUK gave that different advice?
So I think there are two or three reasons. One is that we looked at the same evidence, but I think that Public Health England regarded a lack of evidence as effectively showing that there was no potential AGP production. We took a lack of evidence as being not enough evidence. We also, from a practical point of view, all of us and our instructors have done CPR, and you can see droplets coming out. So we know what happens. We couldn't prove it because we haven't published that, but we know that happens. And lastly, I think the evidence, because we had all been in contact with our colleagues around the world, and especially in Italy, who suggested that full PPE was protective. And latterly, that came out in the urgent review of deaths in healthcare workers, which absolutely showed pretty much the same proportion of deaths amongst healthcare workers as everybody else in the population. The key thing is it showed that those healthcare workers that were working in the highest risk environment, intensive care, seemed to be underrepresented, which definitely suggests that PPE was protective.
So those who are working in intensive care had access to full PPE?
Indeed. And so, lastly, we felt that we had to take a precautionary approach because we had to balance the benefit to the patient with the risk to the health of healthcare workers, but also think about that in a cardiac arrest team who comes to a patient with, as you've said, a 23% chance of survival. If they infect 5 people, those people will then become unavailable for healthcare for other people until they get over their COVID. And so there were a variety of issues.
Thank you. I think it was you, Professor Wiley, as the President of the Resuscitation Council, who engaged in a considerable amount of correspondence, meetings and so on with Public Health England over that period. That was from, I think, the initial divergence in advice was the 27th of March 2020, right through until the 27th of May 2022. And your aim throughout that period was to try to bring an alignment, I think, between the positions of Public Health England and RC UK on this subject.
Absolutely.
Can you explain why it was that RC UK felt it was important to avoid a divergence of advice to healthcare workers?
Because it's confusing. We were getting inquiries from our own members, resuscitation officers in different trusts, because they were being told one thing by their trust management coming down from PHE, and they were getting only a slightly different message, but it was around PPE from RC UK. So we reached out and had, at the time, and still feel it was a very useful meeting with Mrs. Susan Hopkins, to try and bring things together. At that meeting, we pointed out they had nobody who was an expert on resuscitation informing their group. And she also very helpfully pointed out that we had nobody who was an expert microbiologist or virologist in our group. And therefore, we asked if we could be put in touch with theirs. And we had a subsequent meeting, I think the day after, with those 2 people. And that was helpful.
Nevertheless, it's right, I think, that Public Health England did not change its stance on this PPE guidance. And this recommendation is made by Professor Lockie in his witness statement. In the eventuality of a future pandemic, processes should be put in place early whereby government and arm's-length bodies are encouraged to engage with organisations like RC UK that offer subject matter expertise not immediately available within their own teams. Does it follow from that you did not consider that the engagement you received from Public Health England was constructive?
So the engagement with the microbiologist and virologist was hugely constructive and helpful to us, but it actually confirmed our view, because at that we were told they were less worried about aerosol-generating particles and much more concerned about droplets. In fact, that was proven not to be true in the end, but we knew that droplets were produced by compressions.
Focusing on the level of engagement that you got from Public Health England rather than that specific meeting.
I apologise. So it's...
In the event of a future pandemic, would you like the engagement that takes place with whatever bodies are in charge of IPC guidance to engage in a similar way, or would you like a different process or a different type of engagement?
It has to be different. I think there has to be an understanding of what other organisations bring to the table, and the communication needs to be two-way, not one-way command and control.
Can I ask you this? Was any indication given by Public Health England at any time in the course of your engagement with them that concerns about availability of PPE impacted on their approach to that particular question?
No, but after Mrs. Susan Hopkins, we did not really get any acknowledgement of our reaching out.
Thank you. Can we come on, please, to the subject of...
So just before you move on, Michelle, sorry to interrupt. So in your engagement with Public Health England, they're saying there's an absence of evidence. You've explained why that doesn't necessarily mean that there isn't evidence, it just hasn't been found yet. If you didn't get an impression that it was a resource reason behind the decision not to issue the guidance you were seeking, was there any other rational explanation as to why?
Yes, absolutely. And it's important to know that Public Health England, what was put to us was that they did not want any delay in applying CPR to a patient in need. In hospital, that delay is very slight because most of us were in some degree of PPE, and it was a matter of upgrading that quickly whilst a defibrillator was applied. So that was the reason that was put forward to us at the time.
Thank you.
Just building on that, if I may, I think it included in your guidance was that very point, that it would be possible to deliver 3 shocks with a defibrillator whilst the rest of the team upgraded their PPE. Is that correct?
Absolutely, because we knew from data from Wuhan that out of 136 patients with COVID who had a cardiac arrest, only 1 had survived, and that was somebody with a defibrillatable rhythm. So the mortality if you had COVID and a cardiac arrest is huge. It's almost not quite total. And the 1 person who survived because a defibrillator was used, and that corrected the rhythm.
So the key intervention
was to put the defibrillator on.
And it wouldn't be necessary to upgrade to full PPE when that was being done?
No, because you can place that and give the shocks, up to 3 shocks, whilst you're putting the PPE on.
Thank you. If we could move on, please, to the subject of DNA CPRs, do not attempt cardiopulmonary resuscitation, and advanced care planning, and deal with some of the paperwork, as it were. First of all, the DNA CPR notice. The inquiry heard yesterday from Professor Summers and Dr. Sundara on the use of DNA CPR notices and also respect forms from the perspective of intensive care clinicians. And they have explained how those are usually encountered in intensive care. Paper forms, usually red bordered forms. And we saw a DNA CPR form yesterday. I think we can get up 227411. This is, in fact, the All Wales DNA CPR form, so that should be used across any settings in Wales. We heard yesterday that there isn't a single standard form for use in England. I think that's right.
I think that's correct, yes.
And do you know about the position in relation to Scotland or Northern Ireland, whether there's one form?
I do not know at all about Northern Ireland. I don't know for certain about Scotland, but Scotland certainly had a unified approach ahead of England in terms of implementing this, but I don't know the details.
We can take that down now. Thank you, Lawrence. We heard yesterday how DNA CPR notices are encountered in intensive care, and also that those discussions were sometimes held with patients or more commonly with their loved ones because the patients wouldn't have capacity at that point. Would you usually expect those decisions about DNA CPR to have been taken prior to the point that the patient is very unwell, not conscious, and going into ICU?
So that is the ideal situation. Of course, in the pandemic, there was a very fast, quickly developing problem where people deteriorated surprisingly quickly. And so that might not have occurred, or might have occurred at speed.
So ideally, if these conversations were going to be had, it would be preferable for those discussions to be taking place soon after the patient was admitted to hospital. Would that be correct?
Absolutely. But really, a wider discussion would be better if there is time and skill.
I think you've explained that those DNA CPR notices can be made in any setting, and so if they're made outside of a hospital setting, that notice should travel with the patient to the hospital. I think that's correct.
Yes.
If a DNA CPR notice has been made in a community setting or in primary care, is it the view of the Resuscitation Council that ideally should be part of a wider conversation about advanced care planning using the RESPECT form process or an equivalent?
So the short answer is yes. As you heard yesterday, RESPECT is a form of just embedding best practice. It isn't to say that people not using RESPECT were not using best practice, because many of them absolutely were. But it would be best part of a wider conversation so that you know either the patients or the families' views on what is important to them. That's not just a decision about CPR or not. It actually helps govern what is the best care for the patient.
And I think we heard yesterday that there can be a risk that a DNA CPR decision is seen as a decision not to consider other forms of treatment, not to consider escalation of care. So if a DNA CPR notice is just part of a wider advanced care plan, does that alleviate some of the concerns or risks in that?
So we feel that that's a much more open process, so people know that what they're opting in and requiring and wanting and what they're not, as opposed to a single event being dealt with.
Can we look, please, at the current RESPECT form? I think we saw yesterday version 2, which was, I think that was in use at the start of the pandemic, is that correct? But work already was underway at that point on developing version 3. Can we look at, please, INQ 0002516666, page 1, please? I think this was published in September 2020, is that correct?
So it was ready in February and it was aimed to roll out to test it in 5 trusts, but actually, of course, that was delayed because it wasn't an appropriate time to do that at the beginning of a pandemic.
Can we look at some of the, the key differences perhaps between version 2 and version 3? And we see that the first part of that form, number 2, shared understanding of my health and current condition. And there are 3 boxes there, including I have a legal welfare proxy in place in the third box. And then number 3, what matters to me in decisions about my treatment and care in an emergency. So putting these sections into the first person using I and me was a change from version 2, is that right?
It was a change brought about by feedback from both patient and relative groups and also clinicians.
And so why were those changes made? What was hoped to be achieved by that?
Well, 2 things. This is a form about the person and it's what's important to them. It also makes that abundantly clear, we hope, to the clinicians that are having those conversations, that whilst obviously the clinician's expertise is important, everybody has to understand what's important to the patient that is taking part in this.
Thank you. And can we see in what matters to me in decisions about my treatment and care in an emergency, there's also boxes here, what I most value and what I most fear or wish to avoid. I think that was another update to the form to allow patients to express both their ideas of a positive outcome and a negative outcome.
Absolutely, and that is I think, useful for patients themselves, hugely beneficial for people trying to care for them, and I honestly think would be also very helpful for families to know what their loved one is thinking and what their worst fear and the things they most value, because that's not always clear.
Thank you. And under Part 4, clinical recommendations for emergency care and treatment, we can see at the top there are 3 boxes: prioritise extending life, or balance extending life with comfort and valued outcomes, or prioritise comfort. And I think that middle box was an addition, a change from version 3. Rather than 2 alternatives, there was a third option, which was balancing the 2. Is that correct?
That's absolutely correct.
And below that, sorry, just below the 3 boxes, please, still at point 4. There's an open text box for clinical guidance on specific realistic interventions that may or may not be wanted. And you've explained in the witness statement that that is to ensure that there's no conflation between a DNA CPR recommendation and not having escalation of treatment. So all the potential treatment options can be identified and explained whether the patient is in favour or not.
Absolutely. Respect came about by professionals and family members and patients realising that there was a conflation. And I've certainly seen that in patients' families, that they assume that a DNA CPR means no care, which is, as you heard yesterday, not correct at all.
And so we did hear yesterday that there may be sometimes a risk that clinicians might misinterpret a DNA CPR as meaning this patient doesn't want to have certainly escalation of care. But that's, I think, a slightly different point, that families may misunderstand a DNA CPR form also to indicate that.
So I have certainly seen that. I have not witnessed the former.
Have you been made aware of any issues during the pandemic where clinicians seem to be misinterpreting a DNA CPR form? Are you personally aware of anything like that?
So only through reporting in the press, as everybody else, because my areas of expertise are newborn intensive care.
I think you're a neonatalist.
And paediatrics. So yes, so a neonatologist. So I wasn't involved in that side of things in my own trust.
Thank you. We can take the form down now. Thank you. I think that respect form has not been adopted everywhere in England. I think most but not all of the regions of England. I think currently 4 out of 14 Scottish health boards. It's not used at all in England and Wales. One of your recommendations is that the respect process be adopted across all 4 nations of the UK. Do you consider that the absence of a nationally standardised process for advanced care planning creates risks for patient care?
So I think it does. Can I just correct, because it wasn't adopted in Wales, but it has been adopted in 5 out of 7 English health regions, as well as those in Scotland. So I think there is a risk of not having a standardised approach. Originally, when we went into respect, the Resuscitation Council UK has a remit for guidelines teaching in terms of resuscitation. We didn't at that time have the same remit for respect, although we recognised its what we thought was its worth and have supported its development. Now I think one of the lessons out of the pandemic, I would say, is that we do need a standardised approach. I am not here to sell respect, but I think that as a country with 4 nations, we do need a standard approach that would work for patients wherever they are.
You've said that was one of the lessons that came out of the pandemic. And you've also explained that the view of the Resuscitation Council UK was that it was appropriate for clinicians to have advanced care planning discussions with all patients that were admitted to hospital with COVID-19. What do you think is the importance of having conversations about advanced care planning in a pandemic situation?
Well, one of the advantages of Respect is that everything is there on our website for patients or professionals to look at. I think it's about openness and understanding what people wish and want. And that's different for different people. It's different for depending on backgrounds, your beliefs. Lots of things feed into that. So the idea of having a blanket approach will not work.
Do you think, we'll come on to blanket DNA
Okay.
CPRs in a moment, but do you think that these considerations are different in a pandemic situation?
Oh, so I think there are many different pressures in a pandemic for certain, because everybody is under stress. And as you heard yesterday, our acute services and adult intensive care had never come under such pressure before, and they had never seen, with or without CPR decisions, they'd never seen the amount of death over such a short period.
Now, I think during the pandemic, in around March of 2020, there was a lot of national media reports about blanket DNA CPRs. By that, I mean solely on the basis of disability or age, rather than an individualised approach. Did the Resuscitation Council itself receive any reports of either inappropriate DNA CPRs or inappropriate blanket policies about DNA CPRs in healthcare settings?
So from two routes. One was that in a non-specific way, we got questions from our resuscitation departments. Some came through asking for information about that. Certainly in one instance, I know of a specific one of our members whose trust implemented a blanket DNA CPR.
Can I ask you a little about that, please? And I don't want the name of the institution or the trust, or indeed the member that brought that to your attention. What was the nature of that blanket policy? Was it on the basis of disability or on the basis of age?
So age, disability and condition, I think, but I did not see the document myself.
As far as you're aware, it was a written policy?
No, I don't know that. I do not know that.
I see. And having been made aware of that, what steps did you take or the Resuscitation Council take?
So we put out what we felt was a very clear statement on that blanket DNA CPR was not an appropriate way forward and should not be implemented. That was on our website, and that our stance on that has never changed. It also went out to resuscitation departments with whom we were in contact. Not as a document, but as they were notified that there was an update on our website to look at.
And in terms of that particular trust, was there any engagement with that trust or with NHS authorities in relation to that particular issue?
No.
Did you have any mechanism as the Resuscitation Council to deal with that?
No, we didn't. And if I'm brutally honest, I would say that our bandwidth was probably taken up by trying to sort out the issue with guidelines and get on the same page with Public Health England.
Do you think that there should be a mechanism by which, if it transpires that there are these sort of inappropriate blanket policies going on at trust level, how would that be dealt with by the appropriate NHS bodies? Is there a mechanism in place? Should there be if there isn't?
So I know that within trusts, if you have an issue, there are mechanisms to raise it within your own trust. But I think in this situation, especially in a pandemic situation, there should be almost a central clearinghouse for, I have an issue, this is going on, does this need looking at? And that could be devolved, or it could go to the different people within the NHS in different countries.
So that would be at to break it down nation by nation, NHS England level in England, and within the devolved administrations at government level for within the bodies responsible.
Somebody
for
with
NHS.
responsibility for sorting out an issue, which may or may not be the case, because some of this is hearsay. But such a route would have been useful even to us with the guidelines to say, we have a problem here, it is not helping. Can somebody please help us sort this out?
Thank you. In relation to inappropriately made DNA CPR notices then during the pandemic, the inquiry has heard about various concerns. Do you think there should be a systematic review of DNA CPR notices that were made during the pandemic?
So I don't have, I honestly don't have enough information to comment on that. I believe strongly that we need a better system for engaging with patients and their families in terms of what they wish. We didn't get any, quite rightly, we didn't get any patient identifiable issues coming through to us because we were not the correct body to be dealing with that.
If a systematic review of DNA CPR notices was proposed, do you know what that would look like, how that would take place? For example, are these notices usually purely on paper, or are they usually part of an electronic patient record? How easy is it to check?
So that is still a problem. So I can only speak for England, but we are still in various levels of digitisation and electronic patient record. And depending upon where you are, it may be on paper, it may be digital, it might be both, or there might be a different system. So I think it would be quite difficult to look at all of that across the whole of the UK, but there are people better able to answer that question for certain than myself.
In addition to concerns that DNA CPR notices were being made on an inappropriate basis, the inquiry has also heard about poor communication, or sometimes a lack entirely of communication with patients or their loved ones, to explain that a DNA CPR decision has been taken and the reasons for it and the effects of that. What is your view as to how to ensure that clinicians are having these difficult conversations in the right way? Is it a training issue?
So I think that has to, that there is, I think that's on a number of levels. Yes, I think there's a training issue. You know, look at me, I trained a long time ago, and I'm senior, and yet I should be one of the people that's having these discussions, but that doesn't mean to say I'm good at it. The other thing is that families have not been prepared for that kind of discussion, and too many will see it as a negative thing when in actual fact it could be a wholly positive thing about understanding what somebody wants at several stages of their lives. So I think personally that there is more training needed. There's time that people will say, all of the doctors and nurses and healthcare professionals will say, so we need time for that. But actually, I think you'll find that patients value that hugely if you've got time to talk about something like that. And I personally feel that we need a public health information drive to get people to think about this as families and as individuals. What is important to you? Just having that conversation does not mean that you're on a one-way train to anywhere, but it does give you more power to decide how you want to live your life.
If we can come back to this point about training, I think we heard yesterday Professor Summers' understanding was that medical students do receive training on communicating difficult decisions as part of the medical curriculum, and that certainly forms part of the continuing professional education for intensive care specialists,
Yes.
and I think also for members of the Royal College of Physicians. Are you aware whether there's training specifically around advanced care planning, DNA CPR, and having those conversations, either as part of initial training or continuing professional education for other specialisms?
So unfortunately, the answer would be both yes, I am aware, and no, it isn't a national generalised thing. So you will again find areas of excellent practice where that kind of training goes on, both in a mentored way, but also with actors and simulation, so that people get a feel for this. What we're talking about with the Respect Form, it isn't just a decision. It's a much wider thing, and therefore one needs time and some slightly different skills in order to make that useful for the patient and for the family.
Do you also agree with Professor Summers that this sort of training should be embedded in medical training?
I absolutely think it should. And not just medical training, because I honestly believe that it should be part of nursing training. It's actually going to be best for the patient to have the person who is most appropriate for that patient. And with the best will in the world, sometimes we're a bit scary doctors.
Thank you. We also heard yesterday how difficult it was to have those kind of conversations with family members when those conversations couldn't take place face-to-face during the pandemic. So it was over a video call or a telephone call. Were you aware of any training that took place during the pandemic to assist clinicians or nurses in having those kind of conversations through remote means?
So not in the wider context. We certainly did training within our neonatal unit to use online discussions with parents, and also updates for ward rounds because of some of the issues with parents not always being present on ward rounds with our intensive care babies. So again, I'm sure that some training went on, but this was not a generalised thing.
Is that the kind of thing that should be perhaps embedded into pandemic planning and preparedness for the healthcare system, about how to give the sort of advice or have those sort of conversations when it's not face-to-face?
So I think that it is one of the lessons to learn in a different setting. I know that there was huge national learning in terms of safeguarding, in that they had meetings and shared what was happening, and good practice spread. And I'm not aware of that happening in terms of this area of care, which might have been useful and is something that could have been done online.
Thank you. We've already touched on some of your recommendations, Professor Wiley, but I'd like to ask about the recommendations that are made at paragraph 89D and E of Professor Lockie's witness statement. And it's this. Firstly, that everyone has access to conversations with their clinician to explore future options for treatment and care in an emergency when they may not be able to voice their own preferences. These conversations should, wherever possible, happen before they are needed, be communicated to those important to the person, and documented in a format that's readily accessible and understood by emergency care providers. And then the normalising of such conversations in society as a whole, both between the person and clinical team, but also within the family setting, to reduce the need for difficult and challenging decisions to be made when a person becomes so unwell that they cannot voice their preferences. I'd like to ask you, how do we do that? How do we go about normalising these conversations in our society? What needs to happen, and particularly what needs to happen from the healthcare sector?
So, well, I think from a healthcare sector point of view, we need to accept that this is a vital part of care. Within my own field, I will tell trainees that we strive to do the best, we strive for success, but the take-home message is when someone dies, you better get it right, because everybody who survives will remember you forever. It's ingrained, as I think we've seen, in stone. So I think that we need to accept, just as you heard people yesterday and the many good clinicians do, that this is a vital area of practice that we should get right. I think that the other thing that we need to do is that we need to make those conversations part of life. And that needs, I think, especially in Britain, a change of a number of cultures, especially what was thought of as British culture. And that's why I mentioned, I think this would be an excellent long-term public health campaign to say it's okay to talk about these things. And your perspective is going to be very different to somebody who's 23 and collapses on a football field as opposed to somebody my age or older, but also depending upon your culture, your gender. Lots of things go into that. And it's just important that people have those conversations and feel free to have those conversations. Because I think that if we get the message right, it will be an uplifting, freeing thing, not a frightening, terrifying thing, which is how it's come about through the pandemic.
Thank you very much, Professor Wiley. I have no more questions.
Can I just follow up on that, Professor? Supposing everybody changed their habits in the way that you suggest, might be a bit tricky in this country given our traditional attitude to death, but what's concerning me are the IT system. So I accept your advice. I go to my GP and I have this discussion, and my family then know what my wishes are. And then I collapse, I'm taken to hospital. What are the chances of the clinician in the hospital being able to get hold of my GP records?
So you're absolutely correct. I think it's one of the massive failures of care in this country. And I'm old enough to remember 20 billion went on NHS IT systems. I have no idea where that went, because I haven't seen any of it. We just have to get better and more sensible. And there's also a need for responsibility, because it is not beyond the bounds of any of us to think that lots of people will now have alert bracelets when they have a condition that needs to be known to everybody. There are other ways of doing things, as well as having a big centralised IT system. I think that we do need to think about this, and I definitely am not the IT expert to sort it out, but it does need to be sorted, and I think it needs to be given thought for the whole of the UK.
Thank you very much. Mr. Weatherby.
Points I had have been covered. Thank you.
Oh, thank you very much, Mr. Weatherby. I think those are the only questions that were expected for you. Professor Waddy, what happened in your unit during the pandemic?
In the neonatal unit?
Yeah.
From what point of view?
Well, just, I mean, you've heard some of the stories I heard. I mean, any particular lessons that...
Oh, so we too had to have visiting by rota, because we didn't have isolation rooms. Our babies were safely isolated, but the parents were very understanding that the space that we had meant they couldn't all come at once. We instituted a system whereby at the end of ward rounds I would do a summary, and that was posted for them. But there were difficult conversations to be had, both about babies and especially about some mothers and their babies. And this comes again to planning. We had to discuss with some mothers who were going to go to theatre for section that they wouldn't be waking up. And early in the pandemic, there was a 50% chance they would never see their baby.
Oh, we're sorry I asked.
No, it's real, and they you know, I've just got, everything was fine several times. Everything was fine. I think the other thing that we found, that we benefited in my own trust in that we had army doctors and nurses who had dealt with severe infections and setting up hospitals in Africa for Ebola. And they were awesome.
I'm extremely grateful, Professor Wiley. Thank you for obviously everything you did on the front line during the pandemic and continue to do by the sounds of it, and thank you for your help in coming to give evidence.
Thank you so much.
Lady, I think the next witness is to be taken by Mr. Scott.
My lady, may we please call Alex Marshall?
Thank you.
I do solemnly, sincerely and truly declare and affirm that the evidence I shall give shall be the truth, the whole truth, and nothing but the truth.
Good morning, Mr. Marshall.
Good morning.
You're giving evidence today on behalf of the Frontline Migrant Health Workers Group, and you yourself are president of the trade union, the Independent Workers Union of Great Britain. Is that correct?
That's correct.
And during the pandemic, you yourself were working as a courier within the health service?
Yeah, that's right.
And just to provide a bit of understanding about Frontline Migrant Health Workers Group, or FMHWG, as I'll refer to them, that's a collective grouping made up of 3 broad organisations. Is that correct?
That's correct.
So you have 2 trade unions, United Voices of the World and the Independent Workers Union of Great Britain. And then you have another group called Kanlungan, who are a consortium of several Filipino and Southeast and East Asian grassroots community organisations. And I think you're, to be fair, more familiar with the work of the UVW and IWGB more so than Kanlungan, is that right?
Yeah, that's right.
If there are areas where you feel that it's a bit too detailed in terms of Kanlungan, please do feel free to say.
Yeah. So yeah, I think it's good to point out here that I am speaking on behalf of the 3 organisations, 2 of which I'm very comfortable to speak on behalf of. The other, I had the privilege of being nominated to speak on behalf of, which I'm very proud to do today. However, their experiences are something that I have had to spend time with them to try and understand, and I hope to convey that as well as possible today. But yeah, so that's my area where I'm slightly weaker, perhaps.
That's not a problem at all. And in terms of actually, it's not just the people who you represent, you're also speaking on behalf of those people who are in the same position as those people you represent. I think we had the evidence of Professor Bamra, who talked about workers who weren't in a union or weren't aware of a union.
Yeah.
You actually speak on behalf of their voices as well, is that right?
Yeah, so I mean, the work that Kanlungan, the IWGB and UVW do is we represent precarious workers, many of whom, struggle to pay the bills, let alone pay for union membership or anything like that. But the work we do is a microcosm of, what needs to happen across the whole of the UK, and we represent the struggles of tens of thousands, hundreds of thousands of workers. Yeah.
And those type of roles that people you represent will be in our nurses, couriers, cleaners, porters, security officers, private hire drivers, a lot of that sector of the healthcare workers. Is that right?
Yeah, so we represent a huge part of healthcare workers, a lot of whom are deemed as less important than, the primary function of, doctors, nurses, but a lot of the outsourced workers. And you mentioned there about the private hire drivers who, during the course of the pandemic, were sort of bought into essentially the care sector when their employer decided, perhaps as a bit of a PR stunt, to offer nurses and vulnerable patients free rides in taxis. This was despite the fact they had insufficient PPE. A lot of them were clinically vulnerable. A lot of them didn't have the choice to necessarily work. But these guys were basically reappropriated into the care sector.
Let me just take a step back, because what I want to ask you about is the kind of the broad views of a large number of the people who you represent. Because yesterday the inquiry heard oral evidence from a witness who was given the name M3W1. Presumably the evidence of that witness is representative of cleaners across the UK working in both private and NHS hospitals, is that right?
That's right.
But actually, probably the evidence of W1 and the evidence of W2 contained in W2's statement that is to be published, I mean, that's representative of the experiences of outsourced workers, migrant workers working in all types of roles across health systems all across the UK.
Yeah.
Is that a fair description?
Yeah. So, I mean, you will have heard some evidence from individuals, but that is representative of, as I said, tens of thousands of people across the UK. And throughout the course of the pandemic, the three different organisations were presented with various situations of their members, and we responded in the best way possible. And as deeply harrowing and troubling it was to hear of these experiences, it was equally as troubling to know that these weren't unique, these weren't one-offs, that these were situations that thousands of people were struggling with, where their voices weren't being heard, where they were just asking for basic protections so they could do their job, so they could continue to earn, but also so they could protect people and not spread the virus.
There's a lot of information you just gave in that answer. Yeah. There's a couple of words I just want to focus on. You said that the voices weren't being heard. Did outsourced workers, migrant workers, did they feel listened to during the pandemic?
No, I mean, this was a common theme for everyone we represent, and I know way far beyond, is that these were people who, from one day to the next, they went home on a day, they watched the TV, they heard announcements of lockdown. They'd seen this coming months before. January, they had started to see specimens. They started to see a rise in issues of COVID. And they'd seen it coming in. But one day to the next, there were these huge announcements where people were told to stay home. And they turned up the next day at work, and basically nothing had changed for them. And a lot of these workers were making basic demands. These weren't specialists in the spread of viruses or anything like that. These were frontline workers who'd been doing a job and knew they were going to be particularly vulnerable. And they were asking for things to be implemented that would protect them, that would protect their families. But also we knew that we were going into places where there were incredibly vulnerable people. We're talking about cancer wards, we're talking about antenatal wards, we're talking about old people's homes. And we were just asking for things to be put in place to ensure that we weren't spreading the virus more than it was already clearly spreading like wildfire.
So that takes back to one of the other points the words you used, is you talked about protected people. It's not just about protecting yourselves, but it's also protecting patients and others. Is that right?
Yeah, I mean, there's a huge responsibility on these workers. We knew that every single day you're coming into contact with people who are unwell, who are sick, who are vulnerable. And, we were carrying specimens of COVID to and from these places. We were going into crowded lifts. We were going in and out of wards. And we knew that we could be super spreaders if we weren't given sufficient protections in order to try and mitigate against that. And going back to what you asked earlier, despite the fact that so many of our members either individually raising this with management, raising this through their unions, campaigning, were being told no time and time and time again, and relying on government orders which seemed that they'd been composed to keep people safe who were staying at home, not vulnerable people who were heading straight into pick up the exact thing that people were being told to stay home and stay safe from.
Well, let's try and boil it down. Did outsourced workers, did they feel protected during the pandemic by people they work for?
No, I think we felt protected by our colleagues. We felt protected by our unions and organisations that were there. But there was no point throughout the pandemic, through the whole duration of it, not just the relevant period, where we felt that our employers or the state, the government, were actually going the extra mile to think of how they can protect us and keep us safe. There was clear demoralisation. It was a case of when people were going to contract it, not if, and also how bad it would be, and people planning around if I get it, hopefully it's not that bad. Hopefully, I don't spread it within my family. Hopefully I can get back to work in time. Maybe I can even work through it. These were the thoughts that many of the people we represent and beyond were having, because there was no point where we felt people were listening to us, or they were going the extra mile to ensure that the people heading into these incredibly dangerous situations were being looked after.
Do you think that a large number of your workers felt that they had any other option but to go to work?
No, I think, even myself, I had various times where if the burden had been shifted from myself as an individual, I would have stayed home. That I felt like it could have been some symptoms that were coming through, but I didn't feel like I had the choice. And I think so many workers, due to, just not having the money, not having the good enough sick pay, not enough security in place, they just did not have the choice. And they were having to either choose to go into work and risk their lives, or stay at home and potentially face destitution. And that is not a choice that any individual should be making, and that's a choice that should have been taken care of by the employers and the government, who actually had the resources to make that decision for them.
There are two comments, and I'm going to say your statement. It's a statement on behalf of FMHWG that you've adopted. First one's at paragraph 36, where it says the failure to heed the warnings of frontline migrant health workers put patients, the public, and those same workers at greater risk. Could you expand upon what's meant by that?
Well, I think, as I said, a lot of these workers saw the signs coming months before any official implementation of any mitigation to keep people safe was put in place. And the voices were being raised, the alarms were being raised, and the way that the pandemic was handled was it started when that first lockdown started, but it didn't. People were handling swabs with their bare hands, and they saw this all coming. So can you repeat a part of the question?
Sure. Well, I can put the statement up on screen if you'd like to help us see what it actually says.
Oh, it was about it. Yeah, if we'd been listened to.
So it's that one. It's failure to heed the warnings of frontline migrant health workers put patients, the public, and those same workers at greater risk.
Yeah, I totally agree. Obviously this is my statement, but
well, it's a statement you've adopted, so they're not your words.
But no, it was. We were crying out for this. We were talking about being super spreaders. We were asking for the implementation of basic things that would keep more people safe. These were completely ignored. And I believe as a result of it, this led to more deaths, this led to more hospitalities. It was a failure to listen to the very people who were experts in the situation and how to mitigate against it.
Because you say that it seemed like it felt that the pandemic started when lockdown happened. You're talking about these warnings. When were these warnings coming in, roughly? Was it January, February, early March?
Well, I know that my colleagues, when I was working as a medical courier, we were starting to see swabs with yellow labels that said COVID from January. We were starting to see it come in then. We were asking and saying that this isn't safe. I remember some of my colleagues, they went and picked up a swab of COVID that the zip bag had been left open. And this was a guy who had a young child at home. He had a young family. And he came back and he approached me and said, this isn't right. I'm going to go home. I'm going to kill my family. And no one seems to care. They wanted to walk off the job. And we were pushing our company to say, what's going on? And the response was, we'll wait for advice. It's wait and see. And where I was working was a private medical firm. This is a place that makes huge amounts of profits from being experts in medical diagnostics. This is a place that you would think would have not only the PPE that's used for the lab staff and these protections, but would have the kind of understanding of situations to get a little bit ahead of the game. However, due to the fact that we were outsourced workers, we were gig economy workers, there just seemed to be no thought for this section of the workforce as to how we can keep these guys safe. And any of our complaints were made to feel like we were just being annoying, like we were just asking for too much, like they just wanted to silence us. And we saw this coming, and we were raising the alarm. But these are situations that so many of these workers are picking up with day to day. There are power dynamics at play, whether you're on an unstable visa or if you're an outsourced worker or you're working in the gig economy. that we're crying out, like that all of these organisations are dealing with these issues on a daily basis. The pandemic was pouring petrol on a blazing inferno that's already going on for a lot of our members. So we're constantly raising the alarm. Our voices got louder during the pandemic. But as I said, we made some basic demands as to things that could be done to keep not only us safe, but also to keep, the members of the public, the vulnerable patients we were coming into contact. And systematically we were told, no, no, no. And that's why this way of employing people, the way of treating people, the power dynamics, the structural racism, the structural inequalities that are, very much on display, it's a public health issue.
Well, let's. Who do you complain to? If you are an outsourced worker or a migrant worker, for example, because I think you say that these issues arise for both of those kind of groups, those very broad groups. Is that right?
Yeah, definitely.
If you're working for a company which is then contracting you to a private hospital, an NHS hospital, who do you complain to? Who do you talk to?
So I think it's really important to understand that as an outsourced worker, there are these power dynamics at play and the precarity at play, from being a migrant worker as well, from being on a precarious visa, or English not being your first language, or the fact you have dependents back at home that you're having to support, that really make you very scared to speak out on an individual basis. Also, the nature of outsourcing and the visa system, it's decimated the ability to collectivise and build unions. It's very hard doing what we're doing in these three organisations to build this collective voice.
I'm sorry to interrupt. It's just I do have limited powers, Mr. Marshall, as I'm sure you'd appreciate. Yeah. I can't change society, and I just think maybe we're straying beyond what I can and can't find or recommend.
If I could just bring you back to the question, which is about who you complain to when you're working within that healthcare sector.
I just wanted to make that point because you can complain to a manager, but it's very difficult to come forward and make that complaint. You go to your union, you collectivise, and then that collective voice makes it more of a kind of prominent complaint. But this is how you complain. If you're an outsourced worker, you're told to go and complain to the outsourcing company. You don't even complain to the manager who actually oversees the work you're doing in the workplace. So then this gets completely disconnected, and by the time the complaint is heard, it's just not even responded to, or something's been lost in communication and they don't do anything about it.
So in terms of then access to things like PPE, again, somebody in that same situation, who provides the PPE? Is it the hospital? Is it the trust, or is it the company?
So I think in a lot of the situations it was coming through the hospitals. However, the kind of in-house workers were prioritised, so they would get primary access to the PPE, and then the outsourced workers would then get limited access. And what we also saw was that...
Can I just ask why?
Why?
Yes. Why do you think that was?
Why was it prioritised?
Yes.
Because they clearly thought these workers were more important, that they were more so their responsibility than the people who were clearly also integral to the business.
Even if people have been redeployed into what were perceived to be higher risk settings?
Yeah, well, that's exactly what happened. And, we've seen the situation of cleaners, we've seen the situation of couriers and nurses who were given secondary access to PPE, despite the fact that they were not only going into incredibly dangerous places, but also were then going into loads of different rooms, loads of different hospitals, so had the potential to be super spreaders.
One of the aspects in the statement is talking about in April 2020, Can Lungan organised a meeting with NHS managers. It's paragraph 57. I don't know if it's something you're entirely familiar with. And this was about NHS managers verbally acknowledging the disproportionate impact on Filipino staff members with regard to over-representation of nurses in infection, and also assignment to high-risk wards. So it was apparent, I know you said it was apparent prior to March, but it was apparent in April about what the impact was on migrant workers, minority ethnic workers, outsourced workers, and that was being raised. Did it ever feel to those workers like anything actually changed?
No, I don't believe it did. And for a lot of these workers, again, because of their visa status and, that fear of speaking out because of the precarity of the nature in which they're in this country and their employment, they felt that they were pushed into really dangerous situations where they weren't able to push back, where people in more stable working conditions were actually able to say no. And that definitely led to this disproportionate number of people dying.
It's one question that we've been asked to ask. It's in relation to the precarity of the workers. From your members' experience, did the imposition of no recourse to public funds conditions on healthcare workers' immigration status exacerbate the impact of long COVID?
Well, I mean, people were forced back into work before they were able to take the appropriate rest because they were unable to access any support that was needed. People were having to work through when they probably had symptoms which were worsening. So I think access to or having no access to it certainly meant that that it was definitely a contributing factor to this.
Was there a feeling amongst outsourced workers or migrant workers that the availability of PPE within a hostel, whether a private hostel or an NHS hostel, was that driving supply to workers who were actually working in that hostel? Or was it just actually about allocation of roles?
So what do you mean that?
Well, was it supply that the hostels actually had available to them that was then driving about how it was handed out? Or was it actually more a guidance and a principal point?
I think no, there was an issue of supply. I think that was widely known. But when they did come by supply, it didn't seem like there was any forward thinking as to keep getting it in. But it also felt like the in-house staff were given a better quality of PPE. They were given an abundance of it. And many of our workers were given sort of disposable masks that they were told to reuse. They were given gloves that they were wearing throughout the day when they're meant to be disposable gloves. We were given very little instruction as to how to safely use PPE. Even though it was inadequate PPE, we were also given insufficient instruction. So as I said, people were wearing gloves all day long to keep their hands clean of germs. However, they were then touching things, picking up specimens, just using them as. So there was definitely limited supplies given to people. We had cases where people were given a little, 10 millimeter bottle or whatever, a really small bottle of hand sanitizer and told to kind of make sure it lasts. How are you meant to make sure it lasts when you're going in and out of wards where you're meant to be hand sanitizing every single time you touch something? Disposable masks where you go in, you try and get more, and you were told you were being greedy by asking for more. If you question the masks that were being used and said, shouldn't we be using these? You were told to be happy that you've got anything. And that was the kind of discourse that was given to many of our members who dared to ask or dared to question. And what we also saw was people who did question what they were given were sometimes faced with punitive measures, that they were called troublemakers. They were told they were scaring people. They were told that they shouldn't be speaking out, and they were moved into places to keep them out of the way or sent into more dangerous situations. So we actually saw, punitive measures being exercised when people dared to question the kind of inadequate protections that they were given.
And again, everything that you've just been covering there, that's being felt by lots of different workers in lots of different roles across the entirety of the country. Is that right?
Well, that's the whole of the UK and beyond, I'm sure. But this is a dynamic that was playing out. As I said at the beginning, this was not a unique experience to certain individuals. This was a dynamic that was playing out for outsourced, precarious migrant workers all over the UK.
My lady, I'm about to move on to another topic. Is that a convenient moment to have our morning break?
Yes, certainly. past.
All right.
I hope you're warned that we take the breaks that we take, Mr. Marshall.
Mr. Marshall, two very discrete topics before I ask you about recommendations and lessons learned. As far as you're aware, were there any risk assessments done or any kind of formal redeployment processes when workers were redeployed into different areas, different working areas?
Yeah, there were.
And how effective were those risk assessments and processes?
Oh, just in sorry.
Sorry, it was about whether the risk assessments were done rather than whether they were redeployed.
Yeah, I think risk assessments were largely insufficient. I think a lot of the times workers, as you said before, in terms of raising complaints, we had people who were reporting workplaces to the HSE, and very often they weren't responded to. When risk assessments did take place in various workplaces where we have members, they were done quite late. Months into the pandemic, risk assessments were made that should have been done in those months leading up to the first lockdown. Risk assessments don't take long. You can put basic things in place while you continue to assess the situation, but a lot of the time these risk assessments were made when we were very much in the pandemic, when people were getting infected, when people were dying.
But did it feel like anything changed afterwards? Even if one had been done, it's a different matter to have been done to whether there was an output from it.
I think that changes were made, but as I said before, a lot of these changes seem to be the bare minimum, as opposed to going the extra mile for these workers. So social distancing was put in place. There were certain systems that were put in place, but a lot of this seemed too little, too late. But also just too little in general that wasn't actually there to protect the workers, but was just more to show that employers were doing what was, asked of them rather than what they should be doing.
Moving now to lessons learned and recommendations. You heard her ladyship earlier on in terms of the limits of what she's able to do. In terms of lessons learned and recommendations, what would you say are the main lessons learned from the perspective of outsourced workers and migrant workers?
Yeah, so outsourcing within the health sector should be ended. Heading towards another pandemic, if one does happen, or any other crisis like this, it was laid bare how this inequality within the workplace becomes a public health issue and actually contributes to a crisis rather than helps with efficiencies or savings or anything like that. So we need an end to outsourcing. And for everyone to have parity, everyone should have access to the same rights, so they're able to take the appropriate steps.
But in terms of making sure that your voices can be heard?
In terms of voices being heard?
Do you have any recommendations that you would like our ladyship consider to make sure that there's a better listening?
Yeah, so I think
are outsourced.
Yeah, so I think that also in the build-up, and I think it's great that we're able to have our voices heard now. Obviously, this is retrospective, but I think workers' voices need to be at the centre of, we need to be listening to the workers who are on the front line, who are crying out for things to be implemented. And I think that always needs to be at the centre of making any changes. So as we reflect on what happened, we need to go deeper and to talk to workers and ensure that the things they were crying out for, enough money to be able to take time off work, the inequality they're facing on a daily basis, this needs to be considered and acted on, not just left to be something that people are still being subjected to today.
Thank you, Mr. Marshall. My lady, I have no further questions.
No, I think there's some questions. Mr. Weatherby.
Thank you very much. Mr. Marshall, I've got just a few questions on behalf of the COVID Bereaved Families for Justice UK. And they're all about the effect of the hostile environment policy on migrant workers. And they're based around some evidence. So a study and a report, which I think you've had the opportunity of looking at in the last day or two, certainly. And it's the Camlungen Consortium and RAPAR report. Obviously, you've told us about Camlungen. Now, RAPAR is a well-known refugee and asylum research organisation based in Manchester, I think. And they conducted a study of Filipino workers in the context of COVID-19 between May and June of 2020. And we have the report. I don't think we'll need to refer to it, but I'm going to give the reference just for the record, which is INQ 30235-265. And for anybody who wants to look at it, it's really page 4 I'm going to concentrate on. But the report looked at the impact of the hostile environment policies on migrant workers in the context of COVID-19. The hostile environment was a government policy from at least 2012, and that was directed at undocumented migrants in the UK, yes. And so the first question I want to ask is that the evidence about this in this study was based around a group of Filipino workers, and of course there are many Filipino workers within the healthcare sector. But is it your experience and from your knowledge of your union members and the people you work with that this study is reflective of the experience of people with precarious immigration status as a whole within the healthcare sector?
Yeah, certainly.
So the study itself, and I'm going to deal with it in very broad outline because I don't want to take too much time up here, but in what ways did the hostile environment policies lead to workers being faced with a choice in terms of, for example, risking getting the virus or becoming destitute, being not in employment? In what ways did the hostile environment policies lead to that dilemma?
So the hostile environment policies feeds into the people I'm representing here today are both people on the precarious visas who are coming from the Philippines who have their work tied to their visas, and if they do push back, they can find themselves fired and they have only 2 months to then try and find different work. So, the risks of pushing back. Also, outsourced work, the gig economy is heavily reliant on migrants who are filtered into this. But the hostile environment contributes. So can you just repeat the end of the question there?
Yeah, I was just asking you how these policies impacted on workers with precarious immigration status. But I mean, the words the report use on page 4 is that they were forced into, quote, informal exploitative employment and, quote, no work, no pay.
Yeah.
So is one of the effects of those policies that migrant workers with precarious status were required to work when otherwise they might have.
Yeah, definitely. I mean, almost every worker, I'm speaking on behalf of predominantly migrant workers who are subjected to these policies, they don't have the security that a lot of in-house workers do, a lot of employees do. Yeah. And as a result of this, they were forced to continually make these choices individually, whether they stay home and stay safe and recover from whatever illness they have, or they go to work and get paid. And this was something that individuals were having to make on a daily basis.
Yes.
Where they literally did not have, I picked 2 choices there, but they're not really choices, are they?
Yes.
Every time someone is going to go to work and continue to earn over staying home, and their existence is so hand to mouth. A lot of people cannot quite comprehend that literally missing a day's work, you're making up for it weeks, months after that happening.
And that applied to outsourced workers generally, but particularly where people have precarious immigration status, and they would be scared that they would lose their employment as well.
You miss a day's work, your manager is chasing you. A lot of the time they don't trust you, and this can lead to you losing your job. And when you've got people who are reliant on you back in the country that you might have left, that your visa is reliant on it, it's just not a choice, that you have to just continue to.
And I think the report went on to say that additional to those points, that migrants with precarious status were pushed into overcrowded housing, and they had fear and isolation, which prevented them accessing support and led to mental health problems. Is that right?
Yeah. I mean, people were they had limited choices. They were forced into situations, be that housing, be that more dangerous situations at work, because they just did not feel like they could push back and have their voices heard.
Now, that's the employment side and the precarious nature of that. But in terms of migrant workers accessing healthcare themselves, how did these policies impact that access?
I think what's really important to understand is also the hostile environment is so deeply entrenched in the society that we live in that you even have situations with people who can access these resources who are so scared to access them because they think they're unwelcome, they think they're going to be deported, they think that they are just choosing not to because they don't feel welcome, because they fear of repercussions. So that's how deeply entrenched it is, let alone for people who might well be undocumented, who might have no recourse to public funds. They just are so terrified.
And I think those are the 2 points that the report highlighted, isn't it? That there was a fear of being reported to immigration authorities on the one hand, and there were also prohibitive charges for treatment on the other. Thank you very much.
But also as a result, we had organisations like Canlingen who were having to set up like these safe spaces where people could access vaccination, where people could access support. The IWGB and UVW also had to set up similar spaces where people could access PPE because people saw them as a safe space where they felt welcome, whereas across the rest of society, they were on the one hand made to feel unwelcome, however they were being applauded every evening for the service they were providing the population to counter a pandemic that was spreading and killing so many people.
Thank you, Mr. Marshall.
Thank you, Mr. Weatherby. Mr. Marshall, that completes the questions we have for you. You are a superb advocate for your cause. You spoke very eloquently about the horrid problems that people you represent suffered. So thank you very much for your...
Thank you very much.
My lady, may I please call Mr. Matthew Stringer, who can be sworn.
I swear by Almighty God
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
and nothing but the truth. Thank you.
I hope we haven't kept you waiting too long.
You're early, in fact.
Your full name, please.
Matthew Stringer.
Mr. Stringer, you are the Chief Executive Officer of the Royal National Institute for Blind People. Is that a role you've held since May 2019?
That's right, yeah.
You have provided a statement to the inquiry representing the collective experience of the members of the Disability Charities Consortium, that's the DCC.
Yeah.
And for reference, that statement is INQ 000 235594. Introduce us, please, Mr. Stringer, to the DCC. Which charities is it made up of, and what are its aims?
It's made up of 9 charities, so it's the RNIB, the RNID, Royal National Institute of Deaf People, SENSE, SCOPE, the National Autistic Society, Leonard Cheshire, MenCap, Mind, and the Business Disability Forum. And we've come together as a group for about 15 years, meaningfully, to provide, a sort of group that supports the 16 million disabled people in the UK. And that group, with the weight we bring collectively, engages with ministers, influences national strategy on disability, and clearly, has engaged across the health service and other related bodies over 15 years.
Can we start with some basics? First, definitions. Under the Equality Act, do we define disability in this way? A person has a disability if they have a physical or mental impairment which has a substantial and long-term adverse effect on their ability to carry out normal day-to-day activities.
Yes, that's right.
Building on that, how do we define when a person has complex disabilities?
I mean, complex disabilities would be a number of disabilities coming together. I mean, clearly we represent people who have a particular disability. So my own charity supports people who are blind and visually impaired. That's about 2 million people in the UK. Clearly some of those people have other disabilities, might be learning disabilities, people who are deaf as well as blind. And so you get the point that there are layers of disability that can build up that make someone's life more complex than just having one singular disability.
Next, please, the key figures. You've told us there are around 16 million disabled people in the UK. Approximately, that is one in how many of us?
It's about 20% of the population. If you take, we're about 70 million, 16 million is about 1 in 5 of the population.
Now, of that 16 million, is it right that 1.6 million have complex disabilities, according to the definition you've just shared?
Yes, I think so. I mean, I think if you just break down some of the statistics in terms of the number of people that we support, how that breaks down, there's 1.6 million with complex disabilities. We think there's 1.5 million with a learning disability. As I said, there's 2 million people have some sort of visual impairment. There's 12 million have some sort of hearing loss, actually. 700,000 people have autism. So that 16 million, you can see, breaks down across a number of different disability characteristics, and there's obviously some overlap when we go back to the point about complexity.
Now, with those figures in mind, can we move to another set of figures?
Yeah.
In respect of mortality amongst disabled people during the pandemic? At your paragraph 14, you refer to data published by the Office for National Statistics, which examined deaths from COVID-19 between January and November 2020. Help us, Mr. Stringer, with what that data revealed.
Well, I think it's pretty shameful data, really, that talk to the fact that of the 50,000 deaths between Jan and November of 2020, 30,000 of the 50,000 were disabled people. So that is 60% of the total, when, as we've just been speaking about, disabled people represent 20% of the UK population. So a very, very high disproportionate impact on disabled people through the time we're talking about, January to November 2020.
You go on at your paragraph 15 to refer to further data published by the ONS in November 2022 in respect of working age people with hearing and visual impairments. What did that tell us, please?
Well, it told us that working age people with a hearing and visual impairment were 12 times more likely to die than those that didn't have a hearing and visual impairment. So again, a very disproportionate number compared to what you would expect.
And then finally this, at paragraph 17, you refer to data published by the Learning Disability Mortality Review. What do we learn from that?
Well, again, a disproportionate outcome. So people who have a learning disability were 6 times more likely to die, and that rose to 30 times more likely for adults between 18 and 34.
Now, when we are considering these figures, should we or should we not be thinking about other factors that might have contributed to these mortality rates? For example, that disabled people are on average older, that they experience higher levels of comorbidities, socioeconomic deprivation, and the barriers they face in accessing care.
Yes, potentially, but I think one of the things we feel as a DCC group is we haven't done enough analysis of these headline numbers to really understand what is driving this disproportionate outcome. There has been some further studies done, but even now we're sitting here not really getting under the skin of why there were 60% of people that died in that first year of COVID who were disabled versus the 20% sort of proportion that they represent in the population. All the things you've mentioned clearly would play a part, but it's an easy thing to say, well, that's the reason why we can accept that disproportionality. We don't think that's right. That's an easy thing to assume, but we think that's too easy to assume. And we will be advocating for further analysis to be done so we can really get under the skin of that data and then do something about the lessons that come from it. And that is an incomplete picture at the moment.
do you see this as being reflective of wider, more fundamental issues with the collection of data about disabled people more generally?
Well, I think, clearly people have been computing data through COVID, and really trying to get to understand it. I think through the first year, this information wasn't really known. It really became, first mortality data came out in June 2020, and then we got some further data in February 2021. So we're almost a year into COVID before I think we really started to see, this direction of travel that we've been talking about over the last few minutes. I think, we, as I say, since then, there's been further things done. There's been, information sought on the government's national autism strategy, for example, which we think, again, has some flaws in it. I think the fundamental point remains that there is work to be done to really understand that data at a more detailed, granular level, to really understand some of the sort of intersectionality issues that you've hinted at in your questions, to really give us much more insight into what really happened and then do something about it.
We haven't been able to refer this morning to mortality data for autistic people. Is that because we don't have reliable data?
Well, again, I think, that the headline, the number of deaths that I've talked about, being able to break that down in a way that really understands, what caused it, is a gap in our knowledge. There's been a government's national autism strategy, from 2021. It's ongoing. The National, Autistic Society would say to us that actually the way the government is collecting that data, and did collect it through the pandemic, was collecting it on people who were in regulated CQC registered services, which clearly is one piece of data which is valid, but it's not the complete picture, which needed to include people of autism who were living at home and in other locations. So again, it makes my point that the data collection we've had has not necessarily been as full as it should have been, whether it's on autism or the general picture.
Yes, and in fact, in your statement, you say there is no means of recording autism on death certificates, and it is not regularly recorded in hospital data.
Yes, that's right. Yeah.
Turning next, please, to the DCC's concerns about the care received by disabled people during the pandemic.
Yeah.
And I'll start with this, please. The reasonable adjustments in healthcare settings for those with disabilities. Is it right that one of the DCC's primary concerns is that the restrictions in respect of hospital visiting had a disproportionate impact on disabled people because they needed someone in hospital with them?
Yes, I think that's right. I think there's two key points maybe to draw out your question. I mean, the first one is the guidance that came out initially in April, and then April 2020, then subsequently was updated, was quite high level. It was quite blunt. It didn't have disabled people's input into shaping it in a much more nuanced way.
I wonder, Mr. String, if we might look at the guidance so you can, make your answer whole. Can we please go to INQ 60132? So this is the 8th of April guidance. We have a list of the only exceptional circumstances where one visitor, an immediate family member or carer, will be permitted to visit are below. And at the final bullet we read, you are supporting someone with a mental health issue such as dementia, a learning disability or autism, where not being present would cause the patient to be distressed.
Yes, so as I was just saying before, I think, these 4 bullet points, and you've drawn the attention to the last one, are quite high level. Clearly that last bullet point doesn't cover everybody who might have a disability. It doesn't talk about people who have Down syndrome. It doesn't talk about people who are deaf, people who are blind. So it's quite a sort of blunt instrument, which leaves as much open to interpretation by the people who are trying to apply this as it does help them. So, this was not a very valuable document or helpful document in a sense. I can understand what we were trying to do, and it was trying to be positive in showing that people needed to be accompanied. It obviously, it was alert to that need. What it didn't do was go into enough detail, to both support people with different disabilities, but also to give the health service the appropriate sort of advice and input so they could do the right thing in supporting patients.
Are you able to give us an example of the further detail to support that you would have liked to have seen in this guidance?
Well, I can maybe just give some examples of some of the beneficiaries that we've seen across the DCC group. So, you know, there was a blind lady who was a full mental faculty who was going through a medical procedure which was nothing to do with COVID. She was denied her partner being there with her, and her partner, her husband, had to take out a sort of power of attorney to accompany his wife to that health visit or that health process, you know, because the hospital wouldn't allow him to accompany her, which we would have said should have been allowed by this sort of advice. So, and there's a number of examples we've got across the different charities whereby people, you know, were not accompanied in a way that we would have advocated and probably the guidance should have allowed through 2020.
Yes. Can we go now to INQ 000 330865? This is the 5th of June 2020 guidance, which replaced the 8th of April guidance. It's right, isn't it, that the paragraph we have just read together, that final bullet point, doesn't appear in the June guidance?
No, it doesn't.
What we do have is this on page 2, please. Penultimate bullet point. Other people who are in attendance to support the needs of the patient, for example, a familiar carer, supporter, personal assistant, should not be counted as an additional visitor. Patients may be accompanied where appropriate and necessary to assist with the patient's communication and/or to meet the patient's health or social care needs. Mr. Stringer, how does the language used here compare to that used in the April 2020 version?
Well, I mean, clearly it is fuller, and I think has taken probably reference back to April that was probably quite quick and quite high level. So, you know, there is more thought and detail in here. I still think we would say this updated version 2 months on was not created with enough input from disabled people who were able to provide that nuance and that insight that I mentioned earlier to make it a much more sort of thoughtful and relevant document. I think one of the problems is that guidance, you know, certainly early in COVID was issued at quite a sort of high level, quite a blanket level. Clearly it had to be done quite quickly, we understand that. But it didn't, as I say, address some of the nuance and the difference that was required, and also for those people trying to apply it, you know, left it quite uncertain, quite what you had to do in certain situations when different types of disabled patients might have presented themselves. So this will be a move on after 2 months, but we don't think it did the full job that was required.
Can I just ask in relation to that you just mentioned a point that I was thinking about, the recipient of this guidance.
Yeah.
The more you try to broaden it to include the people you ought to be including, the harder it gets for the recipient of the guidance to interpret it, doesn't it? Isn't that one of the problems with making it?
Yes, it does. But if you take that argument to its final conclusion, you then say, well, we don't support disabled people and the difference that they present is too difficult. And we will believe that's not an acceptable position. We think that the health service should be able to support people of different disabilities.
Were you or your organisation made aware of patients facing difficulties in bringing a supporter or a carer into hospital after the June 2020 guidance was issued?
Yes, as I said, I think the example I gave was after June with the lady who was going through an experience and had to get her husband to take a power of attorney so he could attend. We have another example of a lady going through who was pregnant, who's one of our employees actually, he was blind, who was going through pregnancy and again had to do that you know, in isolation without the support of a partner and family. So yes, I mean there are examples of that.
Next, please, remote care. By reference to one or two examples, can you help us with the ways in which a phone or a video consultation is not going to be suitable for someone with a disability?
I mean, I think, you know, health processes moved to being remote from, or some moved to being remote from being face to face. I mean, it is a double-edged sword. There were some people who were able to use technology, would have welcomed the ability to do it remotely because they didn't have to travel. They weren't then get exposed to COVID. So we're not saying that every remote procedure was a problem. That would be the wrong thing to assert. However, clearly, for people who are, people with autism, who are used to a familiar process, they're used to familiar individuals, they're used to a familiar setting, for that to be moved to something which was sort of two-dimensional and impersonal is clearly a challenge. And so you can see how, for many people who are used to a physical and got comfort from a physical interaction, to be moved to something which was remote, would be challenging.
With one eye on the future, could remote care be made fully inclusive, such that no individuals with the disabilities we have discussed would be unable to access it?
I think it needs to be a mixed position. As I said, I think we can't deny the march of technology. For reasons of efficiency and appropriateness, certain remote processes we think are a good thing actually, and as I say, patients welcome them. I think the thing is to be able to provide the appropriate process for the individual. And be able to have that for the individual and see the individual as an individual who can choose between having a physical, sort of personal experience or being happy to rely on something that's more remote where technology is used. And I think, it's that ability to be able to offer that sort of bespoke service, that bespoke relevant service to each individual patient, I think is a critical answer to your question, as opposed to seeing it as a binary thing between remote versus physical only.
Yes. So that it may be that there will always need to be a place for face-to-face consultation.
Yeah, I think, as I say, a number of people, people with autism, people who are deaf, who were taking, appropriate comfort and benefit from visual clues, which you get much more when you are face-to-face with someone. There are many people who would, for those reasons, want to have a physical interaction and would see an impersonal remote interaction as being very much of second best and potentially quite worrying and quite challenging. So yes, I think we absolutely need to make sure that physical approach is still part of our health service provision, yeah.
The move to remote care came alongside a reduction in routine medical appointments.
Yeah.
Can you help us, please? How were disabled people particularly affected by this?
Well, I think, there was the, I think, first of all, disabled people, found it much more difficult to navigate society in COVID. If you are blind and you're going out in society, you can't be guided because of social distancing rules. You are worried about social distancing. You don't necessarily have the technology, to rely on to move to a remote process. People were very anxious about going out, and provision, was restricted. So we've seen across all our beneficiaries, a massive fall off in the number of people who were actively taking on or undergoing their routine health appointments, partly because they didn't feel confident to go out and do it, and partly because the health service was not able to offer those. If I just put some stats to that, just to make the point. I mean, from an eye health perspective, we saw a 23% reduction in eye tests from 2020 to 2019. There was a 28% drop off in referrals to ophthalmology. There was an up to 40% reduction in ophthalmology outpatients, and there was 235,000 necessary eye surgeries were missed or delayed in 2020. So you can see that people did not feel confident to go out and engage with a health appointment, and actually the provision of that was reduced as well. The RNID, surveyed 384 respondents in September 2020, and people who were deaf or had some sort of hearing loss, 60% were put off seeking medical advice, and ONS put a report out in September 2020 talking to 47% of people with hearing impairment had access to healthcare impacted. So I think it was a sort of bit of a pincer movement here, really, in that the provision of non-COVID health declined, reduced, and people's confidence to go and engage with it also reduced.
Could you slow down a little?
Yeah, no problem.
Can I move next, please, to the concerns about the use of DNA CPR notices? Is it fair to set out in headline terms the DCC's concerns as being threefold? First, that DNA CPR notices were being issued in a blanket fashion to fit and healthy disabled people of working age. Second, often without consultation with either the patient or, if the patient lacked capacity, their family. And third, that there were instances of DNA CPR notices being confused with do not treat notices.
I mean, the answer is yes to all those three questions. Let me try and embellish. I mean, I think first of all, MenCap has spoken very well to this in their My Health, My Life report from December 2020. I think there was some confused guidance. So NICE issued guidance on the 20th of March, and then there was a 2-week period where there was a lot of input into that because we felt that guidance sort of encouraged or opened the door, so that slightly more blanket approach, and that was sort of rowed back on the 3rd of April, so about 2 weeks later. But we felt that the sort of cat was out of the bag in essence, or the horse had bolted over those 2 weeks, with that guidance sort of permeating into the health service, and people then taking that encouragement to maybe use DNA CPR notices in a slightly more sort of, to use your word, blanket fashion. And we've seen evidence of that from our membership in essence. There was evidence from MenCap of a GP applying blanket notices to the people under the care of that MenCap institution. And we've seen individuals go through hospital when their family and carers were not aware that a DNA CPR had been applied to that individual. So, we can see that everything you've said in your question, was evident through that period. As I say, not necessarily helped by the guidance that went out on the 20th, which, whilst it was rescinded on the 3rd of April, still left 2 weeks whereby some unfortunate, guidance did permeate the health service.
Let's have a look at the letter of the 3rd of April. Please, can we have on screen INQ 000 216 427. Thank you. First paragraph. We are writing to ensure that there is clarity in relation to the use of the clinical frailty scale and the use of DNA CPR with younger patients, those with a stable long-term physical need, learning disability or autism. Pausing there, Mr. Stringer, only to signpost that the use of the clinical frailty scale will be addressed in detail with other witnesses in due course. Turning to page 2, please. We have in the final paragraph, it is imperative that decisions regarding appropriateness of admission to hospital and for assessment and treatment for people with learning disabilities and/or autism are made on an individual basis and in consultation with their family and/or paid carers, taking into account the person's usual physical health, the severity of any coexisting conditions, and their frailty at the time of examination. Treatment decisions should not be made on the basis of the presence of learning disability and/or autism alone. I think you used the phrase, the cat was already out of the bag. Can you help us, in your view, why did this letter not adequately address the concerns that were surrounding the use of DNA CPR notices at that time?
Well, I think there was a simple point that, advice having been promulgated 2 weeks before, it was very difficult to sort of get the genie back in the bottle 2 weeks later, whatever that advice had been. So that had obviously permeated through the health service, and it was very difficult to think you could completely sort of rescind that advice and replace it. So I think that's a simple point. I mean, I think, again, these are complex things, DNA CPRs, and I think, there is a complexity to this which I think is the underlying problem here, where, everything that subsequent sort of reviews showed were evident here. I think you have problems with, health service under complete strain in 2020, having to think, as I said earlier, about individual people as individuals with a disability that needed to be thought about on an individual basis, with enough time to consider all the underlying issues pertaining to that individual, with enough training, enough time on the health service workers to be able to provide that service, and enough sort of leadership and management to make this a priority. And I think all those things, were difficult through a time of incredible strain in the health service. So, I think the advice in March, rather sort of allowed people to take slightly more of a blanket approach, and even though this advice 2 weeks later was trying to sort of rescind that and be a bit more thoughtful, as this paragraph shows, to encourage people to be more thoughtful in their approach, I still think it was asking a lot of the system at the time to be able to do that.
Almost a year later, in March 2021, the Care Quality Commission published a review of DNA CPR decisions based on work conducted between November 2020 and January 2021. Please can we have on screen INQ 00216428. At page 2, please, starting on the penultimate paragraph, we read, people's experiences of DNA CPR decisions were varied. We heard that some people felt they had been involved in the decision-making process as part of a holistic conversation about their care. However, others felt that conversations around whether they would want to receive CPR came out of the blue, and that they were not given the time or information to fully understand what was happening or even what a DNA CPR was. In some cases, people were not always aware that a DNA CPR decision was in place. This could be hugely distressing for people and their families and/or carers. Just moving to the next paragraph before I ask you about this. It is concerning that some people across a range of equality groups, including older people, people with dementia, and people with a learning disability, told us that they were not supported to the extent they needed to be in advanced care planning conversations or given the information they needed in an accessible way. Given the dialogue that had taken place between, as you say, the National Autistic Society, which led to the April 2020 letter coming out, how concerned are you by the conclusions of this report in March 2021?
Yeah, I think it shows, almost a year after the correspondence from March and April of 2020, that there were still challenges in the system. There were still challenges, I think, in terms of people, working at the, in the front line of the health service, having enough training, having enough awareness of disabled people to be able to apply a correct approach. I think struggles with time. There were still issues of having access to families and carers to get that rounded view about an individual. And there was, we would surmise, still some challenges in terms of the consistent application of the policy and process from the centre, even after the updated letters of April 2020.
In your view, should there be a systematic review of the DNA CPR notices that were issued during the pandemic?
I think as part of the point I made earlier about understanding the data better than we do know, I think that would be a useful thing for us to investigate. There is concern even now that we still think there's a lingering problem with DNA CPR still being attached to people's records, even in a sort of in a world where we're not in the sort of intense period of the pandemic. So I think some work to understand that, yes, would be a good thing, but I think it also needs to look at what's happening now as much as what's happening sort of 3 or 4 years ago.
Thinking about what's happening now and also looking to the future, what changes would the DCC like to see in the way that DNA CPR decisions are made?
Well, I think the report that we're now looking at from March 2021 has got some actually very good conclusions, actually. So we think, if we can see that properly implemented, both in terms of the understanding of the individual, so a rounded decision can be taken with the right input from family, carers and any other bodies involved, to make sure all the information and all the concerns are properly addressed, and the appropriate training for people in the health service working in this space, to make sure they're aware of their responsibilities, but also to understand, as I say, that they need to take into consideration all those factors I've mentioned. So, we think the findings were actually pretty good. It's a question of getting those properly fully implemented. We would still advocate for.
Next, please, shielding. At your paragraph 58, you observe that many disabled people were not identified as being clinically extremely vulnerable. Can you help us with the effect that this had on those people?
Well, I think it obviously made people more open to harm or open to problems because they weren't assessed as being clinically vulnerable or clinically extremely vulnerable. I think we would feel that there was quite a sort of clinical lens applied to this consideration at the time, and what wasn't maybe brought into play early enough was a more rounded view of individuals to look at things that went purely beyond the clinical and looked a bit more at socio-economic, looked at the domestic circumstances, and was able to create a fuller picture of an individual to work out whether or not they should be thought of as clinically vulnerable or clinically extremely vulnerable. And as we saw, people with Down syndrome were added to that list in autumn 2020 because through the first few months of COVID there had been an assessment of what I've just said, that there was a sort of more rounded view to be taken about people with Down syndrome. The data showed their greater vulnerability, and they were added to the list. There were still challenges then on how that was applied to those individuals with Down syndrome. But I think the point being that I think people realised, maybe 6 months into COVID, that actually a more rounded view needed to be taken in consideration of who should be clinically vulnerable or clinically extremely vulnerable.
How could that rounded view have been taken into account from the very outset?
Well, as I said, I think in a few of my answers today, I think, there was a clinical lens applied to COVID. Disabled people, I think, were seen as a sort of collective. There wasn't enough understanding of the nuance between different types of disability and different potential requirements. In my initial answer about the 16 million disabled people in the UK, I broke down, some of the core groups within that. I think it gave a sense that there are people with very different requirements and very different conditions and different aspects. So, I think, there should have been more thought, even at that quite high level of disability, to some of the challenges that those people would experience societally in getting through COVID, and that extra consideration added to the sort of slightly more limited clinical consideration.
More thought and perhaps early engagement with organisations like the one you represent?
Yes, that sounds a little self-serving if I say yes to that, but I think more insight and more information that comes from the beneficiaries, comes from the lived experience, is critical. And I think, whilst we did have good engagement at different times on different topics, I think, our sense would be that we were always slightly playing catch-up on whichever aspect of COVID we were engaged with. And the problem was that the preparation hadn't been done with that engagement sort of up front, so that we were better prepared. And I think it was evident in your question on people who were clinically vulnerable or clinically extremely vulnerable.
For those that did receive a shielding letter, were those letters always sent in a format they could read?
No, not always. We're going to come on to the broader point about communication. I think one of the challenges that we had from the very start was making sure communication to disabled people was in the accessible format that they could absorb, and clearly it wasn't. So whether that was a shielding letter or any other form of communication, it was a very patchy process and a very patchy, it didn't work very well for disabled people in the communication processes. because accessible communication was not a thread that ran through our response to COVID.
Yes. Just thinking for a moment about someone who receives a shielding letter that they're not able to read. What is the practical impact on that person, that they wouldn't know that they had to shield?
Yes, that's right. I mean, if you can just use the example of someone who's visually impaired, first of all, the letter lands on your door. How do you know what the letter is? I mean, how can you tell from the envelope what's in it? You can't actually read it. If it's not in an accessible format, you rely on someone else, a neighbour or another family member. Often that might be difficult. If you're living on your own, you might be able to do that late in the day. But as I say, the fundamental problem first is you might not even know that letter's arrived in the first place. And therefore, if you don't know or you are late in being able to access the information, clearly it puts yourself at risk if you are being asked to shield, for example.
Moving on to communication issues more broadly then, how would you characterise the accessibility of public health information about COVID-19 for disabled people?
We think it was a real challenge through all of COVID, honestly. We think it started in a difficult way, and whilst there were some improvements, it didn't get to a point whereby, systematically information was accessible for disabled people in the UK. If I could just maybe go into some examples. So we've talked about critical letters around shielding that should have been available for people in their preferred format, whether that's large font, whether that's Braille, and we never really achieved that through COVID. There was some representation with the Cabinet Office and the Department of Health and Social Security, and there were times that we were able to, for example, put the RNIB in there as a helpline, so they knew they could contact us and we could do that. But frankly, putting the RNIB into a letter that's in an inaccessible format is far from a satisfactory answer. And then you have other challenges. So for people who are deaf, the RNID were very keen to try and get British Sign Language interpreters involved in all government and other important communications. And from a UK government perspective, that never happened in a systematic way. When BBC News and sort of BBC One came together, it was achieved. But often the 5 o'clock, daily press conference was conducted without any sign language interpretation. And it can be done. It was done in Wales. It was done in Scotland by the First Ministers, who did have sign language interpreters routinely there for their daily press conferences in the devolved nations.
So, despite engagement by disability charities with the government, the problems persisted throughout the pandemic?
Yes. As I say, we started, I think, from quite a low base. There was engagement. Again, we were engaging in March, I think, individually with people at the Cabinet Office. I certainly did that from an RNIB perspective. We came together in April on a letter that we sent to the Prime Minister, a response from Minister for Disabled People, Justin Tomlinson, in May, talked about setting up a sort of comms group, which happened. But if you look across all the different media of communication through the pandemic, so there were the daily press conferences, there were, we talked about letters, there were government apps, there were social media activity. It was patchy about how those sort of evolved and were fully accessible over time. Made some good progress on things like government websites where they were fully accessible, but things like some of the social media activity, government press conferences, letter communication never really got to a point whereby it was fully accessible in a sort of foolproof way. That just didn't happen.
In your view, were these issues reflective of long-standing, pervasive problems around the accessibility of public information for disabled people?
Yes, I mean, if you go back, one of the things that we would really recommend would be the implementation of the accessible information standards, which has been mandated from 2016, which basically says that information around health, people's engagement with the health service, should be done in an accessible format for that individual. That is ready to go. It's sort of an oven-ready thing. We have been campaigning on it even recently because it's not in place. And if that had been in place before the pandemic, it would have made life so much easier for disabled people to have the confidence that they were going to get their communication in an accessible format.
Mr. Stringer, your statement concludes with this observation. The DCC is concerned that disabled people were treated as an afterthought during the pandemic. To ensure this does not happen again, what lessons or recommendations do you wish this afternoon to share with the inquiry?
Yeah, I think I would say three things. I think a thread through all my answers has been the need to see disabled people as individuals and not as a collective and not as some second-class collective. And I think too often through COVID, whether we were talking about communications, whether we were talking about application of DNA CPRs, whether we've been talking about sort of access to health and guidance to the NHS on how to support disabled people through sort of routine health sort of visits. All too often we can see that there was a sort of blanket approach, there was an unthinking approach, and we were playing catch up throughout that. So I think we need to think about disabled people as individuals and be able to put in place solutions which much more support them as individuals. I think that was a real gap, that we saw exacerbated in COVID. I think the second point is a point I'd like to make about data. I think one of the challenges we have is data flows, which is a real panacea to try and fix. But I think one of the problems we saw was that we didn't know where to go to for data. We didn't know which was a primary data. So if we're looking at, understanding who should be, for example, classed as clinically vulnerable or clinically extremely vulnerable, we had GPs with information. We had local authorities with information on registers. We had the DWP with information from a welfare perspective. And I think one of the problems was that we did not have a sort of single version of the truth or a primary source of data to use that we could have then everyone rode in behind and used that data as something that then drove, a common policy and a policy we all understood, what we were doing with it. I think whilst those data pools aren't perfect, I think we were using different sources of data, which was inconsistent and incomplete through COVID. And the final thing I'd say is what I just said a few minutes ago. We could implement the accessible information standard. That exists. That is not something that has to be created, and will go a long way to providing disabled people with communication in a format they could understand. And I think what is trying to get across that I think we saw from beneficiaries was a real sense of despair and being very forlorn and abandoned through this process, because you weren't getting the communication in a format that you could access, and therefore you weren't getting critical information, on time to do something with. And I think, that was a real problem for disabled people through COVID, and then exacerbated other issues because then you didn't access things and you didn't do things on time. So if we could implement the accessible information standard, which has been ready to go since 2016, that would be a real boon for disabled people in the UK.
A proposal that you offer in your statement is to introduce a mechanism within the policy-making process for new policies to be sense-checked with disabled people or indeed the organisations representing them. Can you give us a sense of how you envisage a process like that operating?
Well, I think the Disability Charity Consortium, are it's the biggest group, it's the best group. It brings the insight we can bring from those millions of people that we support. And I think, the DCC engaging appropriately with national institutions, government, health service, all of which we do to a degree. We have regular ministerial meetings. We met Stephen Timms recently. You go back through the previous administration, regular meetings on national disability strategy with previous Conservative ministers. So the channels are there. I think it is putting in place a more considered process about what those channels are doing and to make sure that we're addressing some of the critical things in time, not using those channels as we did in COVID to sort of play catch up on events where we were already too late actually to address some of these problems that had already started through COVID. So I think the DCC group is a very valid reference point and those contacts are there. It's just a question of codifying and using those on the right things, I think.
Mr. Stringer, thank you. My lady, that's all I ask.
Mr. Weatherby.
Mr. Stringer, I ask questions on behalf of COVID Brief Families for Justice UK, and just a few questions from me, and back to the access and treatment of those with learning disabilities within the healthcare sector, with some questions about the importance of specialist nursing. But I want to concentrate around a report of one of your member organisations, MENCAP, which I think that you've had an opportunity to look at. In terms of providing the inquiry with some evidence here, can I take you straight to that? And perhaps we could have it up on screen. Perhaps if we start with the front page of it, it's INQ 000176404. And just while it's being put up, this is a MENCAP report, which I think you referred to earlier.
Yeah.
And it's entitled Barriers to Healthcare for People with a Learning Disability During the Pandemic. And if we could jump to page 21, please. Again, this is the page, the heading for the relevant section that I want to take you to. And that care for people with a learning disability in hospital. And then the next page, please, and the top part of that page. And so what the report is looking at is reasonable adjustments are vital to accessing healthcare for people with a disability. These can be relatively simple things, as you've already adverted to, such as waiting in a quiet area or being accompanied by a supporter on an overnight stay, or quite complex adjustments requiring whole teams to work together and do something very differently. And sometimes these adjustments need specialist input. So there's quite a big picture here. And then it goes on to talk about the legal requirements and the fact that they weren't affected by the Coronavirus Act. And then this, the third paragraph, it is known that a lack of adjustments to care, even in normal times, can have fatal consequences for people with a learning disability. So as a starting point, that grounds us, doesn't it, in the absolute imperative for proper access and services to be provided for those with learning disabilities in the healthcare sectors. Is that a fair putting?
Yes, but yeah.
Yeah. And then at the bottom of that page, please, the last two paragraphs. This is where MENCAP has surveyed healthcare professionals and nurses in particular. And I'll just read those two paragraphs. Many nurses surveyed by MENCAP were critical of the care that is being given to people with a learning disability during the COVID pandemic, with one participant remarking, quote, "Unfortunately, the support I have witnessed in hospitals falls very short of even basic nursing care." And only 1 in 5 learning disability nurses surveyed said that they'd always seen reasonable adjustments made for people with a learning disability. Those are stark survey findings, aren't they?
I mean, yes, they are, and I think MENCAP have done a very thorough job with this report. It's from December 2020, so it takes, I think, some very real and very raw feedback from the people surveyed, and as you've just highlighted in this extract from the nurses who were providing that care. So I think it's a very relevant, raw, genuine perspective. Yes. Yeah,
raw, genuine, and very much from the people who would be most knowing about it. And of course, it's correct, isn't it, that learning disability nurses, specialist nurses, play an absolutely vital role in ensuring that access and reasonable adjustments are put in place in a hospital setting for people with learning disabilities.
Yes, that's right.
And if we could then go to the bottom of the next page, please. the final paragraph on page 23, COVID-19 has created extra risk that people may need to attend hospital unaccompanied, and infection control measures may have made it more likely that items such as hospital passports and other important communication aids are lost. This will have created extra barriers to people's support needs even being flagged to a hospital to hospital staff in the first place. Sorry, I stumbled over those words, but that really starkly again sets out the entry point of the problems for learning disabled patients during the pandemic, doesn't it?
Yes, I think MENCAP, I think in the report and separately have got some very compelling evidence from individuals and beneficiaries who went through a process whereby they were on their own, unaccompanied, as this paragraph says, but didn't have those items with them, hospital passports, and that sense of the individual, which was sort of lost in them moving through the process on their own, and therefore decisions were taken about their care, which ultimately did involve, for some individuals, DNA, CPR decisions, which were done very much in a sort of two-dimensional way without that rounded view being taken with them.
So the problem started from the outset, the lack of recognition of identifying needs. And then after that, the provision of specialist nurses. Of course, the capacity issues in the healthcare setting and the pandemic itself put enormous strain on staffing. And that meant that many learning disability nurses were redeployed, sometimes leaving no specialist service at all for learning disabled patients. Is that right?
Yes, that's right. I think it comes out in the report there are examples. I think we've seen, pressures on the health service, clearly probably coping with sickness themselves, having to, move resources around, and make some very tough real-time decisions, totally sympathetic to the challenge. Clearly, one of the implications was that people were moved away from, a area of specialty into something else, and those people that relied on that area of specialty were then left, slightly abandoned because that care was no longer there.
I'll come back to slightly abandoned in a moment, if I may. But the last passage of this report, the next page, please, just the top paragraph of it. This is the last reference, page 24. Many healthcare staff have been also redeployed throughout the NHS and may be working in unfamiliar environments, stressed and exhausted, making it harder for them to make adjustments to the care they're providing under such pressures. Among those redeployed were a number of learning disability nurses, meaning that in some trusts there may have been a lack of specialist support for patients needing adjustments to their care. And then some statistics. Around 11% of acute learning disabled nurses we surveyed said they or a team member had been redeployed. For community-based learning disability nurses, it was 34%. One nurse commented, "I was redeployed for 4 weeks to another ward. During this period, there was no specialist learning disability service provided across the trust." And that's evidence of the seriousness of the redeployment issues, isn't it?
Yes, that's right. As I just said earlier, we saw people not having access to that sort of learning disability service because redeployment decisions have been taken. Yes.
So looping back to where we started with the recognition that even in normal times that the lack of provision for people with learning disabilities could be fatal. Would you agree that there is a link between the redeployment and the lack of services and what we've looked at in terms of the mortality statistics in terms of people with learning disabilities?
Yes, potentially. I mean, as I said earlier, I think we need to do some more granular analysis on the mortality stats to really understand what was going on. There might well be, to your question, a link with the support that disappeared from specialist nurses because they were redeployed. Yes, I mean I think that's a fair link, but I think we need to do some more analysis of the data to really be able to prove that empirically.
And of course the inquiry's heard some direct evidence about this. Finally, this in future pandemic planning, learning disability specialist care should be seen as an integral part of the delivery of essential services, shouldn't it? That was a key missing part here.
Yes, it should be, but again, I just refer back to some of my earlier answers. I think there's a general gap in thinking about disabled people in the round and in a full way, and clearly consideration as to the learning disability service provided within the health service is part of that consideration. Yes. So decisions can be taken understanding where that bit slots into that overall improved analysis of what is required to support disabled people through another pandemic. Yes.
That's very helpful. Thank you very much indeed.
Thank you.
Thank you, Mr. Weatherby. That concludes the questions we have for you, Mr. Stringer. Thank you so much indeed for your help and obviously for all the work that you and your other organisations do to help people who so desperately need the support you can provide. Thank you very much indeed.
Thank you, my lady.
I shall return at 22.
All right.